What's the best blood thinner strategy for patients who have both atrial fibrillation and chronic coronary artery disease? Do we give them an oral anticoagulant to help prevent stroke and give them an antiplatelet medicine to help prevent a heart attack? Or is an anticoagulant alone enough? Today, we're going to be discussing a paper that was recently published that may change the way we think about how we treat some of our most complex cardiac patients. We're talking about the Aquatic trial, which was published in the New England Journal of Medicine just last week. It's a study that addresses a very critical question that's been plaguing cardiology for years with some very interesting results. Hi, if you're new here, I'm Herb, the Heart Pharmacist, where we talk about everything pertaining to the heart and heart medications. I've been practicing as a hospital pharmacist for over 15 years with over 10 years of focused cardiac experience, and I'd love to share some of my opinions and views and experiences with some of you to help you make some important decisions pertaining to heart medications. All of these views are my own. Please use this information as education only and not medical advice. We have a lot to cover, so without further ado, let's dive right in. For the longest time, the clinical community has been divided on this. It's the ultimate balancing act. Do you prevent blood clots and strokes and heart attacks with blood thinners, or do you try to prevent a catastrophic bleeding event? It made logical sense to give people an anticoagulant for atrial fibrillation and also an antiplatelet medicine for helping prevent stents from clogging up. But let me tell you, observational studies have been whispering to us for years that this strategy might actually be causing more harm than good by increasing bleeding without a clear benefit in preventing strokes and subsequent heart attacks. And the randomized trials that we've had, they've been a great start, but they had their limitations. We had the OAC alone trial back in 2018, and it was stopped early, so we never really got a full picture. Then we had the AFIRE trial that was done in Japan, published in 2019, which showed that using rivaroxaban in very stable patients with both atrial fibrillation and coronary artery disease may be a reasonable approach. Then we had the Pareto AF, as well as the EPIC CAD study that was done in Korea, most recently published in 2024, adding to the evidence. But still, clinicians were very reluctant to move ahead to proceed with getting rid of the antiplatelet agent earlier because the patients in the trials weren't really the high-risk patients that you may actually see in real-world practice. And that's why the Aquatic trial is so crucial. It was designed to address this exact gap. It's a brave study that I think the authors should be congratulated for trying to tackle such a challenging and important question in our industry. Let's break down how this study was put together, because the design of the study is a big part of why the results are so impactful. The Aquatic trial enrolled patients with chronic CAD who had already been on long-term anticoagulation for atrial fibrillation. Now, what's interesting is their definition of what chronic CAD was. Patients had to be more than 6 months out from their last set of stents. Some might argue that 6 months might be considered a little too early for them to be considered stable, as a lot of the studies and the guidelines also use a 1-year mark as sort of the defining point in which if you can last that long without a recurrent event, that's considered stable. But what makes this trial population so unique and compelling is that they were at very, very high atherosclerotic risk. But this is the reality of the patient that we face every day. So how did they define this? A history of PCI during an acute coronary syndrome or heart attack, or previous stenting in the last 6 months with at least one complex feature, either diabetes, diffuse multivessel disease, chronic kidney disease defined as creatinine clearance of less than 50 mils per minute, prior stent thrombosis, anybody who had peripheral artery disease, these are usually quite significant vasculopaths, history of complex PCI to either the left main artery or any chronic total occlusion stenting or CTO. This is not a typical low-risk population. And the authors were right to highlight this, that their patients in this study had a history of MI in over 70% of the cases, which is about 7 to 8 times higher than what we've seen in older trial. The intervention group was oral anticoagulation plus aspirin versus oral anticoagulation plus placebo. So basically oral anticoagulation alone. Primary efficacy outcome, which was a composite of cardiovascular death, MI, stroke, systemic embolism, coronary revascularization, or acute limb ischemia. And the primary safety was the International Society of Thrombosis and Hemostasis definition for major bleeding. What I really liked was their secondary outcomes were tested in a hierarchical order. Something really interesting about how they did this, though, was that they used something called a net adverse clinical event, and they noted this, and they placed this above all-cause death, which is a bit unconventional. I can only wonder that they would have tried to do this to help boost the number of events for their study. It's a small but possibly significant detail. This trial was a randomized, double-blind, placebo-controlled trial conducted in France across 51 different centers. It was a well-funded study funded by the French Ministry of Health, as well as an unrestricted grant from Bayer Healthcare. Bayer Healthcare is what manufactures aspirin. They planned for 2,000 patients to be enrolled, but the trial was actually stopped early based on the recommendations of the Data and Safety Monitoring Board. This was due to a troubling finding that we'll talk a little bit about later. First, let's look at the baseline characteristics of the patients who were about 72 years old, mostly male, about 85%, with a median CHA2DS2-VASc score of about 4, denoting moderate to high risk for stroke. About 10% of patients had a history of a bypass surgery, with about a median of 9 years since their last surgery, so from a surgical standpoint, they were fairly stable. Interesting to note was that in the oral anticoagulation alone arm, these patients actually had a higher baseline risk of stroke of 12.3% compared to 9% in the aspirin plus oral anticoagulation arm. What about their oral anticoagulant? About 60% of patients were on Apixaban, 25% were on Rivaroxaban, 5% on Dabigatran, and about 10% were on a vitamin K antagonist such as warfarin. I also found it very interesting that if you look in the supplementary appendix, 10 out of 17 patients who were on Dabigatran were on the higher dose as opposed to 110 milligrams twice a day, especially if they're on aspirin. You would think that in this setting where you're adding an antiplatelet medicine that they would have brought it down to 110 twice a day. For those who are on the Rivaroxaban 15 milligrams, I don't really know how their kidney function is really like. So that's the usual recommendation. If your creatinine clearance falls within 30 to 50 mils per minute, but they don't really specify that in this study. The results for the primary efficacy outcome was definitely not in favor of adding aspirin. The event rate was 16.9% in the aspirin plus oral anticoagulation arm versus 12.1% in the oral anticoagulation plus placebo, with a hazard ratio of 1.53 and p-value of 0.02, which is statistically significant. The trial not only failed to show superiority for aspirin, but it actually even showed harm. And because of this, the hierarchical testing was also stopped. It's likely that the slightly higher baseline stroke rate in the OAC alone arm made the MACE outcome not statistically significant for when they did that secondary analysis. But the overall trend was pretty clear. But the most staggering finding was the one that actually stopped the trial. It was the difference in all-cause death. The aspirin group actually had a higher risk of death, and here's the kicker: it wasn't from fatal bleeding. When you look at the supplementary data, the cause of death was different between the groups. Numerically, sudden death was 5 in the aspirin plus anticoagulation arm and 3 in the anticoagulation alone arm. Non-cardiovascular causes of death were also higher, with 11 patients dying from either infection or sepsis in the aspirin plus anticoagulation arm versus 7 that were in the anticoagulation alone group. The most mysterious part was the unknown causes. We're talking 14 deaths in the aspirin plus anticoagulation arm versus 4 in the oral anticoagulation alone arm. That's 10 patients of unexplained causes of death. This is the biggest puzzle of this entire trial. While it's reassuring that these people didn't die from a bleeding episode, for me this is very unsettling because we don't really know how they died. Was it a sudden acute event that could not be categorized properly? Possibly. I don't know. So what are the big takeaways from this trial and some lingering questions? So number one, why were there more deaths? We've covered this, but it's worth repeating. The sudden deaths, and especially the high number of unknown deaths in the aspirin group, are a major red flag. Number two, aspirin. Why did they choose aspirin compared to something like clopidogrel, which we know that probably doesn't carry as high of a bleeding risk compared to aspirin? Would the results still have been the same if they had used clopidogrel instead of aspirin? It's a great question, and it's something that other trials may need to address, because we do know that aspirin is a direct mucosal irritant and can cause things like stomach ulcers and nasty GI bleeds. So another thing to talk about is the generalizability of this study. So this study was done in France. French interventional cardiologists tend to do more revascularization procedures. I don't know if this really affects the trial in any way, but at least we do know that there weren't more stent thrombosis events in the oral anticoagulation alone arm. Do the results of this trial apply to other parts of the world? It's a point of debate. Now, we should always be talking about the power of these clinical trials. And when we talk about power, we're talking about statistical power. So yes, this trial was technically underpowered because it was stopped early, but because the difference in all-cause death was so drastic in the aspirin arm that continuing the trial would have been very, very unethical. You just can't let people die to reach a statistical endpoint. So this study gives us a crucial piece of data to change our thinking. Now, if I were a betting person, I would bet that an interventional cardiologist would still be slow to change their practice based on the results of this study. I can almost hear the conversation now. Well, you didn't see what the coronary anatomy looked like. You weren't in the cath lab when we were trying to put in the stent. It was a really challenging case, so I'm going to recommend keeping an antiplatelet on for longer. And that's the culture. It's hard to overcome the feeling of wanting to protect a patient from a rare and catastrophic stent thrombosis event. But the good news about this trial was that they specifically looked at these high-risk people with complex coronary anatomy. So the bottom line is this: the Aquatic trial provides compelling, randomized, double-blind evidence that patients on oral anticoagulant for atrial fibrillation who are in the chronic phase of coronary artery disease, adding aspirin just isn't effective, but it may actually be even harmful. Overall, I think it was a well-done study. It was transparent about its limitations. I think it's a huge step forward in helping us make a very complex yet critical decision for our patients. If you found this video useful, consider giving it a like, share it with a friend, or even hit the subscribe button if you want to follow for more cardiology and heart medication related content. As always, thank you all for tuning in. Stay happy, healthy, safe, and remember to say no to drugs.